And welcome to the Dr. Bob Show. Have you ever been bothered with shortness of breath? Do you have a cough? Do you bring up any sputum? Has your doctor said you're having a little touch of bronchitis? Will that bronchitis get worse? Will it damage your lungs? Will it lead to COPD or chronic bronchitis? Have you ever smoked? Or do you just have asthma with cough and wheeze and shortness of breath? Or could it be an overlap of both? We'll be spending most of the show answering those questions. My guest is Dr. James Shamiyeh. Dr. Shamiyeh is a board-certified lung specialist, pulmonologist. He'll be answering our questions. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about breaking news on lowering your cholesterol and the effects of emotion on your body. Do you know that emotions can damage almost every part of your body? A lot of information for you. You'll want to stay tuned to the Dr. Bob Show. We're talking with Dr. James Shamiyeh, board-certified pulmonologist, lung specialist, and we're going to be talking about a difference between asthma and COPD, and somehow they're related with each other. Jim, welcome to the Dr. Bob Show.
Thank you.
Let's talk a little bit about asthma. What are some of the characteristics of asthma, and then we'll go to COPD.
So, asthma is a condition that, first of all, tends to affect people that may be younger, although its onset can be at any age. The symptoms are shortness of breath, wheezing, coughing, and there's usually a strong allergy component to asthma.
So at an early age, and there's frequently allergy that's there, and they have cough and wheeze, how do you make the diagnosis?
So, one thing that can be helpful is there's a test called spirometry. And spirometry is a test you do at your doctor's office where you breathe into an apparatus and it really assesses your airflow out of your lungs. And that's one thing about asthma is that generally you're getting air in okay, but sometimes there tends to be an issue getting air out. However,
so does the person feel like they can't get the air out, or they feel like they can't get it in?
It depends, because if their lungs are really tight and their airways are tight, sometimes it can be a restricted feeling, like they can't get the air in.
But the real problem is it's trapped and they can't get the air out.
That's exactly right.
And spirometry, lung studies can give you information on that?
They can. If the person's having symptoms when they do the spirometry, then often it will be abnormal. But the other thing about asthma is it really varies over time. And so it might be that the person does the test on a day when they're not having any symptoms at all and feeling good, and their spirometry could be completely normal.
And other days, if it's really bad, it could look worse than it is?
Absolutely, absolutely.
So how do you tell in the office if it's really bad and you can improve it? What kind of tests do you do?
Well, in the office, I mean, a lot of the diagnosis of asthma is still based on the history and the symptoms. And so if I have somebody who describes a tightness in their chest, if they describe wheezing, a lot of times nighttime symptoms are very common in asthma. In the office, we can do the spirometry, and then we'll have the person do the breathing test, and then we'll have them take an inhaler, and then we'll repeat the breathing test afterward. And if we see a substantial improvement just before and after, that also very much supports the idea of asthma.
Are there certain criteria for so much improvement to establish the diagnosis?
We'd like to see if the airflow started abnormal and we see a 12% increase in the airflow. That really tells us something.
So does everybody does the normal lungs have a tone and you get a little bit of improvement, everybody? Or just asthmatics?
Well, the normal lung has some tone and you might see a little bit of improvement, but really when you're starting to talk about 12% or more, you're really talking about more kind of people with asthma.
So if you do spirometry and then you use a bronchodilator and you get 15% or 12%. Does that make the diagnosis?
Not necessarily. There still could be that asthma is not the only lung disease where you can see that happen.
But it's the way you establish asthma. If you don't have any improvement, does that mean you don't have asthma, or does that mean most likely you don't, or it depends on the history and the physical?
Well, it means, it certainly argues against it, but for example, certain medications, if you were already taking them, might make it where you don't get that 12%. And so you really want to look at the entire picture, what the patient tells you, when you listen to their lungs, and then also what the spirometry test says.
Young person, some allergies, a lot at nighttime. Other triggers would be like what? Cold air, warm air, or what?
It's certainly cold air tends to be a trigger. Exercise can be a trigger. Different people have different triggers, and so that's one of the recurrent things about asthma is there's a lot of variability.
Is an infection a trigger frequently?
It certainly, an infection can trigger a flare-up of asthma. It doesn't cause asthma, but it can trigger a flare-up.
And make it worse.
Yep.
So what's going on in the lungs with asthma? We usually think there's two things, spasm. What is?
Right, so in the lungs, inflammation is the key word for asthma. And so the bronchial tubes, the lining is inflamed, and that can cause it to become thickened and cause more mucus to be inside. All of that then leads to obstruction of that airflow. And then the bronchial tube itself has muscle along its side, and that muscle can get irritated and constrict, and then that also narrows down the airway. So all these different factors are at play, but the common theme of all of them is that they constrict the airway, which makes air not be able to get out of the lung, and then it can get trapped.
Our goals for somebody that has asthma would be 50% better, 75% better, 102% better.
Well, in most asthmatics, not all, the goal is really symptom control. I mean, I don't want to say 100% better, but honestly, that's what we try to do. And that may be with medicines. It may be that the person never gets to the point where they can't take medicine, but we really want daily control of asthma symptoms and a normal quality of life.
So that's asthma.
Yep.
Let's flip over to COPD. What's it like, and how does it in general differ?
So COPD, I mean, first of all, there are some similarities in terms of symptoms. I mean, coughing, wheezing, shortness of breath are similar, and even some of the medicines used to treat them are similar. But the fundamental difference in COPD is that it's related to some sort of exposure over time. Now, by far, the most common exposure is cigarette smoke, but there are other exposures, industrial exposures and things like that. But because there has to be a time period of that exposure, COPD tends to affect patients when they're older. Now, I don't want to give the impression that asthma can't start older. I mean, I have patients in their 50s and 60s who I diagnose with new onset asthma, but COPD generally has that period of time.
Now, what is spirometry? How does it differ from, you get improvement with somebody's asthma? What happens with COPD, chronic obstructive pulmonary disease?
So COPD is also an airflow issue. But one of the fundamental differences between it and asthma is that even though you may get some improvement on spirometry after you start medications, generally it doesn't go back to normal. So there's certain element of COPD airflow issues that are permanent. Doesn't mean it doesn't respond to medicine, but it just means it can't be completely reversed.
So you've got some irreversible changes that are always going to be there, but you can't help them. Now, what makes it worse, chronic bronchitis?
So
COPD,
it certainly, similar things as far as weather changes can make it worse, humidity changes, upper respiratory infections can cause it to flare up. Some of the same things can make asthma worse and COPD worse.
Is there any possibility that people could have both? They can have COPD and asthma at the same time?
There is described an overlap where they can have both.
And that's what we're going to be talking about. Is there a combination that some people can have asthma and COPD at the same time? What is the treatment of that, and what's the long-term outcome? You'll want to stay tuned for those answers. We're talking with Dr. James Shamiyeh, board-certified pulmonologist. We've been talking about the difference of asthma and COPD. Asthma, younger age, reversible airway disease. Medications treat it. We expect the patient to be nigh unto normal with treatment, but they may have to take their medicines. Whereas somebody with COPD has obstruction to the airflow, but not all of it will be reversible. Some will be. There's improvement for the patient, but they're still having some residual problem in the airway. Is that right?
That's right. Yep.
So let's go back and let's talk about treatment of asthma, and then we'll talk about treatment of COPD. So what's the treatment of asthma?
So if asthma is primarily an inflammatory condition of the airway or the bronchial tubes, then the cornerstone of treatment is an anti-inflammatory medication that's delivered to the bronchial tubes, and that's an inhaled steroid.
Inhaled steroids. Now, are steroids dangerous?
Steroids certainly, when you take them orally, have some side effects, potentially if you're on them for prolonged periods of time. We pay attention to the potential side effects for inhaled steroids, but you're not getting it in the rest of your body in the same way as if you're taking a steroid pill.
And you're putting it down where the problem is, so you don't have to worry so much about taking the pills.
Exactly.
So you've got inhaled steroids, and what do?
They basically fight that inflammation, and then the idea, what people with asthma do when they have symptoms is they take their rescue inhaler, and that gives them some immediate relief. And what we're shooting for is if we can get the inflammation in the bronchial tubes under control, then the patient won't need their rescue inhaler nearly as much.
So the rescue inhaler would be what? What would be an example?
So albuterol, there's a lot of different brands.
What does it do?
So albuterol relaxes the constriction of the bronchial tube and basically opens it up, but it doesn't last forever. It stays in the system just for several hours.
So is there a combination medication with an inhaled steroid and a reliever bronchodilator medications?
There are multiple combination on the market. Now, those are not rescue inhalers. Those are just the albuterols. But things that people are familiar with, like Advair, Symbicort, Dulera as examples, are combination that have both a steroid and a longer-acting bronchodilating medicine to help open that bronchial tube up.
So the treatment of COPD then, with asthma, we've got anti-inflammation and bronchodilators.
Right.
And we can get those lungs back to nigh unto normal. What about COPD?
So COPD, the inflammation, although there's still inflammation, it doesn't really dominate the whole picture. So although we do use inhaled steroids, they're not the cornerstone of treatment. The cornerstone are different types of long-acting bronchodilating medicines, things that last 12 or 24 hours once you take them, and they provide this smooth, consistent opening of the bronchial tubes. Spiriva would be an example of a medication like that.
So is that a bronchodilator, the same kind you get in Advair, Dulera, or Symbicort, or is it a different kind of bronchodilator?
There are a few different families of bronchodilators. There is overlap in some of them. So, for example, some of those combination inhalers that we talked about are used in both asthma and in COPD. But then some of the other medicines are much more focused on COPD. Spiriva would be an example of that.
So Spiriva opens up the lungs on a level area, hopefully for 24 hours.
Right.
So what about somebody that's got COPD? What are their flares? We talked about with asthma what the flares were. What are flares of COPD?
So a flare-up of COPD could be caused, usually it's some sort of a respiratory infection, but it could be an exposure, and that's just where you have increased shortness of breath, increased cough, the sputum may change, and there is a similarity between the two in that the flare-ups are both treated with steroids, this time more pill steroids, and then potentially with antibiotics, more so in COPD than in asthma.
So let's get to the pulling these two together, where we've got COPD and asthma overlapping each other. So how can that be? How can somebody have both of them?
Well, first of all, it can be tricky because a lot of the symptoms are similar. But basically, for example, you might have somebody who is at an older age of onset who had an exposure, but then also has a really prominent allergy component to it. And then you do testing, and then you do that spirometry test, and you give them the puffer, and they may not get complete improvement, but maybe instead of 12%, they get 20% improvement. When the features of the two conditions truly seem to overlap, it may be the person has some of both.
Is that common?
I wouldn't say it's everybody who walks in the door, but we definitely see it.
You certainly see a lot of people that smoked a lot and have chronic bronchitis, but they also had allergies that have persisted since childhood, so they've got some asthma and chronic bronchitis. How do you treat that patient?
So you essentially have to decide which of the two, asthma or COPD, you think is the dominant, and that's the one you would generally start with. If you're not sure, I tend to then favor starting with the asthma kind of mentality, and the reason for that is that asthma can really have a nice response. And so why not start with the thing that has the potential to have a dramatic impact,
Sure,
and then work on some of the COPD things which may not respond as dramatically.
and some of the medicines that you use for the overlap would be the same?
Correct, and that's one of the nice things about it is if you're not sure, there's enough overlap between the medications that if you give one of those combination inhalers, you're kind of treating both at the same time.
So that makes it easier, or you have to be more perceptive in which one you're trying to get better and what you have to tell the patient. It seems like it would really be something that really have to communicate with the patient.
Well, I think you have to communicate that they may have some of both, but in a way, it opens the doors more. I actually have more options of things to treat with if I'm treating an overlap of COPD and asthma than if I'm treating either one by itself.
So do you sometimes use the Spiriva and the Advair? Would you ever use both? They're sort of in different families.
You would absolutely use both, and we have many patients with COPD, particularly more advanced COPD, but not always, but patients who would be on both. Whereas in asthma, Spiriva would be an add-on when you're really starting to have more substantial asthma problems.
What kind of results do you get? Does it vary with how severe the overlap is, how much it's leading towards COPD? It makes it more difficult. What does the person expect? What can they expect to be able to do?
Well, with both conditions, first and foremost, we want to prevent the progression. And so one critical thing with that is cigarette smoking. It impacts both conditions, and we absolutely counsel folks to stop smoking.
What does smoking do to chronic COPD or to asthma?
So,
it's terrifying, but what does it do?
So in COPD, it kind of continues the progression of the disease process, and so there's ongoing damage. In asthma, it can do some of that, but also it can simply be the thing that causes asthma to flare up. And one fundamental thing in both conditions is we don't want the flare-ups. We want to prevent those. And so medicines, avoiding triggers, avoiding cigarette smoke, we want to do things that avoid those.
Where does exercise and oxygen and breathing treatments, where does that fit in?
So for example, breathing treatments would be part of both conditions. Oxygen is going to be more of a COPD thing. We don't, although it's not impossible, we certainly don't think of oxygen being something that someone with even lifelong asthma would necessarily need. Exercise is going to be dependent on how the person is doing at that particular time and the advice of their physician.
And is there ways to exercise the lungs, taking deep breaths, blowing out hard, Do you have pulmonary rehab?
So pulmonary rehab is something that is more specific for COPD. It is a formal program where the patient goes, is taught breathing techniques, taught the way that they can exercise. Generally, asthma would not be, again, if we can get asthma under control with medications and avoidance of the triggers, then the longer term damage that rehab would address hopefully doesn't happen.
James, if somebody comes in and they've got either asthma or overlap syndrome or COPD, what is the outlook for most of them? Can you improve most people?
So most people, regardless of which of those conditions they have, can get improvement. It really depends on where we're starting, and it also just depends on how much of the asthma and how much of the COPD. But with adherence to medications and the right medications, we can generally get improvement even with somebody who's starting with really substantial COPD.
And I think that's the great message.
Yeah.
There's, even though part of the COPD is irreversible, there's treatment. We can help you. We can make your life more functional. I really am enamored by what the pulmonologist does to help these people, to help them be more productive in life. And James Shamiyeh, you're one of those that does it.
Well, thank you very much, and it's a pleasure to be here.
Great show. If you have COPD, chronic bronchitis, asthma, know that there's treatment that can get you better. Hook yourself up with the right doctor and know that improvement can be. And now we've got more information for you, a new breakthrough on lowering your cholesterol and what does emotion do to damage the body. You'd be absolutely surprised. So we've got to learn how to control our emotions. You'll want to stay tuned, a lot of information. I want to thank Dr. James Shamiyeh. A wonderful discussion on overlap between asthma and COPD. Now, for questions from you, the viewer, that I think will be important to your health. Question number one, Dr. Bob, is lowering the cholesterol effective if I already have heart disease? It's an excellent question. We know that if people have an elevated cholesterol and no risk factors, if we lower the cholesterol, that they have less events of having heart problems. So it's good to know your cholesterol, it's good to lower it, exercise, diet, but most likely medications. So what happens if I have risk factors? What if I've been a smoker and damaged my heart? What if I've had a heart attack? What if I'm overweight? What if I have a sedentary lifestyle? What if I have a family history of heart disease? Those are some risk factors that we have. And so if you have risk factors, new study shows that if you lower your cholesterol, that you have a 25% less chance of having a heart event, a cardiovascular event. So let's look at that again. If you've got some damage to your heart, if you know you have some heart disease, know that lowering your cholesterol is an important part of your treatment, and now statistics show that. So really, there's very few people that lowering the cholesterol won't help. Know that if you take cholesterol, that it has side effects. Sometimes it's muscle aches. And if those muscle aches are due to the statin drug, then it may cause breakdown of muscles. We call that rhabdomyolysis. If so, the globin in the myoglobin, the muscle, can clog up the kidneys. We can go into kidney failure. So if you have pain with statins, talk it over with your doctor. Most time it goes away. Usually it's not something severe. Question number two. Dr. Bob, what are the effects of stress and how do I control it? Well, there's good stress and there's bad stress, but most people think of stress as emotions, and emotions can bother the body. We can have stiff neck, we can have headaches, we can have eye discomfort, we can have belly problems, we can have heartburn. It affects the mind, the mood. We can get anxious, we can get irritable, we can get depressed. Emotions can do all of that. And what about other things that it can cause? Well, it can cause the body we can overeat, we can smoke, we can drink too much. So emotions can cause a wide variety of things that harm our health. If any of those things bother the body, it puts stress on the body, and so it may cause your blood pressure to be high. It may cause stress on your heart. So what can we do about it? Well, there's a lot that we can do about it. We can design a program which would be understand what it's causing your emotions. We can exercise on a regular basis. We can do yoga and meditation. We can relax and take time for ourselves and our society. We simply don't take enough time for ourselves. We're too busy. We've got too many things to do. I don't have time. I don't have time to get better. I can't do relaxation. Yes, you can. Sit down and listen to some music. Yes, get in a rocking chair and breathe in some fresh air out on the porch. Relax a little bit. Do something for yourself. Go to a movie. Find time for yourself, because if you do, you'll find that maybe that headache and neck pressure will go away. Maybe your overeating will go away. Maybe too much alcohol will go away. Maybe you can stop smoking. Maybe you can find that indeed taking care of yourself is the thing that it's going to take to get you better. That's all the time that we have for this show. Hope you've enjoyed it as much as I have. Remember, the four things that we like to talk about. Number one, exercise. Exercise does so much. It's probably the most important thing other than laughter. Exercise will help reduce your weight. It will help reduce the stress and emotions. It will help you lose weight. It will make you feel better. You'll get a runner's high. And when you feel better, the people around you will feel better and you'll be more productive. I can remember Billy Graham being very, very tired until he started exercising, and then all his fatigue and being tired all the time went away. Get 7.5 hours of sleep. Sleep is so important. And in our society, sometimes we think that we're macho and that we can get by in less than 7.5 hours. No, you need your sleep. It will rest the body. It will make you feel better. You'll be happier. You'll perform better. Start the day off eating properly. It's really less portions, and you know what good foods are. Don't eat bad foods. Don't eat fried, fatty foods. Make the food that you eat good food, small portion, and do that regular. And most of all, we're trying to get to that on our closing here, is that laughter in your life. You know, if you laugh a lot, you're going to be healthy. So find that person that you laugh with, giggle a lot, and you'll stay